Urinary incontinence. Definition. Urinary incontinence is a problem with bladder and sphincter control. It is the uncontrolled leaking of urine. Urinary incontinence, UI, also known as involuntary urination, is any uncontrolled leakage of urine. It may have a large impact on quality of life. Incontinence is a common condition and happens because of problems with the muscles and nerves that help the bladder hold or release urine. Risk factors. The following are risk factors linked to urinary incontinence. Obesity. This puts extra pressure on the bladder and surrounding muscles. It weakens the muscles, making leakage more likely when the person sneezes or coughs. Smoking. This can lead to a chronic cough, which may result in episodes of incontinence. Gender. Women have a higher chance of experiencing stress incontinence than men, especially if they have had children. Old age. The muscles in the bladder and urethra weaken with age. Some diseases and conditions, diabetes, kidney disease, spinal cord injury, and neurologic diseases, for example, a stroke, increase the risk. Prostate disease. Incontinence may present after prostate surgery or radiation therapy. Causes. Urinary tract infection. This infection can irritate bladder, leaving person with a strong urge to urinate and, sometimes, incontinence. Pregnancy and childbirth. The strain from carrying a baby and giving birth can weaken muscles, ligaments, and nerves in the pelvis, bringing on incontinence. Menopause. Stress incontinence and OAB are more common in menopause when estrogen levels drop. Estrogen helps keep the bladder, pelvic muscles, and urethra healthy. Prostate problems. Men who have had prostate surgery or have an enlarged prostate are more likely to have incontinence. Smoking. Experts aren't sure why, but smokers are at a higher risk for incontinence than non-smokers. Being overweight. Excess pounds can put pressure on the bladder, causing it to leak urine. Medical conditions. Some conditions damage nerves or muscles, such as diabetes, multiple sclerosis, and Parkinson's disease. Anxiety can also trigger incontinence in some people. Medications. Some medications, such as diuretics, water pills, sedatives, sleeping pills, and some drugs to treat depression can cause incontinence or make it worse. Hysterectomy. The muscles and ligaments that support the bladder may be damaged when patients have surgery to remove uterus. Types. There are 4 main types of urinary incontinence. Stress incontinence, also known as effort incontinence, is essentially due to incomplete closure of the urinary sphincter, due to problems in the sphincter itself or insufficient strength of the pelvic floor muscles supporting it. This type of incontinence is when urine leaks during activities that increase intra-abdominal pressure, such as coughing, sneezing, or bearing down. Urge incontinence is an involuntary loss of urine occurring while suddenly feeling the need or urge to urinate, usually secondary to overactive bladder syndrome. Overflow incontinence is the incontinence that happens suddenly without feeling an urge to urinate and without necessarily doing any physical activities. It is also known as underactive bladder syndrome. This usually happens with chronic obstruction of the bladder outlet or with diseases damaging the nerves supplying the urinary bladder. The urine stretches the bladder without the person feeling the pressure, and eventually, it overwhelms the ability of the urethral sphincter to hold it back. Mixed incontinence contains symptoms of multiple other types of incontinence. It is not uncommon in the elderly female population and can sometimes be complicated by urinary retention. Other types. Functional incontinence occurs when a person recognizes the need to urinate but cannot make it to the bathroom. The loss of urine may be large. There are several causes of functional incontinence including confusion, dementia, poor eyesight, mobility or dexterity, unwillingness to the toilet because of depression or anxiety or inebriation due to alcohol. Functional incontinence can also occur in certain circumstances where no biological or medical problem is present. For example, a person may recognize the need to urinate but may be in a situation where there is no toilet nearby or access to a toilet is restricted. Structural incontinence, Rarely, structural problems can cause incontinence, usually diagnosed in childhood, for example, an ectopic ureter. Fistulas caused by obstetric and gynecologic trauma or injury are commonly known as obstetric fistulas and can lead to incontinence. These types of vaginal fistulas include, most commonly, vesicovaginal fistula and, more rarely, ureterovaginal fistula. These may be difficult to diagnose. The use of standard techniques along with a vaginogram or radiologically viewing the vaginal vault with installation of contrast media. Nocturnal enuresis is episodic UI while asleep. It is normal in young children. Transient incontinence is temporary incontinence most often seen in pregnant women when it subsequently resolves after the birth of the child. Giggle incontinence is an involuntary response to laughter. It usually affects children. Double incontinence. There is also a related condition for defecation known as fecal incontinence. Due to involvement of the same muscle group, levator ani, in bladder and bowel continence, patients with urinary incontinence are more likely to have fecal incontinence in addition. This is sometimes termed double incontinence. Post-void dribbling is the phenomenon where urine remaining in the urethra after voiding the bladder slowly leaks out after urination. Coital incontinence, CI, is urinary leakage that occurs during either penetration or orgasm and can occur with a sexual partner or with masturbation. It has been reported to occur in 10% to 24% of sexually active women with pelvic floor disorders. Climacturia is urinary incontinence at the moment of orgasm. It can be a result of radical prostatectomy. Symptoms. The main symptom is the unintentional release, leakage, of urine. When and how this occurs will depend on the type of urinary incontinence. Diagnosis. History taking. Take a history from the person identified to have UI. History taking should include past medical, surgical, obstetric and gynecological history. Medications. Duration of UI. Circumstances of leak e.g. coughing, straining, sense of urgency. Bladder storage symptoms e.g. frequency, urgency, nocturia. Any voiding symptoms e.g. intermittency, poor stream, post-void dribble, straining. Psychological and social history. Physical exam. The physician may examine the vagina and check the strength of the pelvic floor muscles. They may examine the rectum of a male patient to determine whether the prostate gland is enlarged. Urinalysis. Tests are carried out for signs of infection and abnormalities. Blood test. This can assess kidney function. Post-void residual, PVR, measurement. This assesses how much urine is left in the bladder after urinating. Pelvic ultrasound provides an image and may help detect any abnormalities. Stress test. The patient will be asked to apply sudden pressure while the doctor looks out for loss of urine. Urodynamic testing. This determines how much pressure the bladder and urinary sphincter muscle can withstand. Cystogram. An X-ray procedure provides an image of the bladder. Cystoscopy. A thin tube with a lens at the end is inserted into the urethra. The doctor can view any abnormalities in the urinary tract. Medical management. Pharmacological agents. Topical estrogen may reinforce tissue in the urethra and vaginal areas and lessen some of the symptoms. Oxybutynin, tolterodine, solifenacin are anticholinergics which block signals that trigger abnormal bladder contractions associated with overactive bladder. Mirabegron relaxes the bladder muscle and increases the amount of urine the bladder muscle can hold. Duloxetine is sometimes used for stress incontinence in place of surgery. Desmopressing reduces urine production at night. Imipramine, tofranil, is a tricyclic antidepressant. Medical devices. The following medical devices are designed for females. Urethral inserts. A woman inserts the device before activity and takes it out when she wants to urinate. Pessary, a rigid ring inserted into the vagina and worn all day. It helps hold the bladder up and prevent leakage. Radiofrequency therapy. Tissue in the lower urinary tract is heated. When it heals, it is usually firmer, often resulting in better urinary control. Botox, botulinum toxin type A injected into the bladder muscle. This can help those with an overactive bladder. Bulking agents, injected into tissue around the urethra. These help keep the urethra closed. Sacral nerve stimulator. This is implanted under the skin of the buttock. A wire connects it to a nerve that runs from the spinal cord to the bladder. The wire emits an electrical pulse that stimulates the nerve, helping bladder control. Other options. Urinary catheter, a tube that goes from the bladder, through the urethra, out of the body into a bag which collects urine. Absorbent pads, a wide range of absorbent pads is available to purchase at pharmacies and supermarkets, as well as online. Bladder training. By using the restroom at set times instead of waiting for the urge, patient can slowly get control over his bladder and increase the time between bathroom trips. Kegel exercises. Squeezing the pelvic floor muscles, which hold up the bladder, can make them stronger and help stop leaks. Here is how to do them. To get a feel for the muscles you are targeting, stop the stream of urine when you are going to the bathroom. If you feel a sense of pulling, you are squeezing the right muscles. When your bladder is empty, squeeze your pelvic floor muscles for a count of 5, and then relax them for 5 seconds. That's 1 rep. Aim for 3 sets of 10 reps per day. Biofeedback. An electrical patch is placed on the skin over the bladder and urethra. The patch is connected to a monitor so patient can see when the muscles contract. This will help patient learn to control them to prevent leaks. Nerve stimulation. Sends quick pulses of electricity to muscles around the bladder, which may help strengthen them. Surgical management. Surgery is an option if other therapies do not work. Women who plan to have children should discuss surgical options with the doctor before making the decision. Sling procedures. A mesh is inserted under the neck of the bladder to help support the urethra and stop urine from leaking out. Colpo suspension. Lifting the bladder neck can help relieve stress incontinence. Artificial sphincter. An artificial sphincter, or valve, may be inserted to control the flow of urine from the bladder into the urethra. Nursing management. Diagnosis. Times stress urinary incontinence related to weak pelvic floor musculature and tissue atrophy. Times urge urinary incontinence related to excess intake of caffeine and citrus juices. Times impaired skin integrity related to constant contact of urine with perineal tissues. Times ineffective coping related to inability to control urine leakage. Expected outcomes. The expected outcomes are: times remain dry between voidings and at night. Times demonstrate improved perineal muscle strength. Times regain and maintain perineal skin integrity. Times return to her previous level of social activity. Planning and implementation. Times teach how to identify pelvic floor muscles and how to perform Kegel exercises. Times suggest drinking decaffeinated tea and non-citrus fruit juices, grape, apple, and cranberry. Times encourage to minimize fluid intake after evening meal. Times change afternoon dose of furosemide from 9 o'clock p.m. to 3 o'clock p.m. Times instruct to void by the clock, gradually increasing intervals from every 45 to 60 minutes to every 2 to 2.5 hours. Advised to maintain shorter voiding intervals for 2 to 3 hours after furosemide doses. Times teach to cleanse perineal area, wiping front to back, after each voiding or incident of urine leakage. Times introduce commercial products available for clothing and furniture protection, encouraging experimentation to identify the most helpful product. Times provide a commode for bedside at night and adequate lighting to prevent injury. Times schedule follow-up visits and evaluations to reinforce teaching. Evaluation. Patient will state that she is doing very well, experiencing occasional leakage of small amounts of urine, primarily when sneezing, coughing, or laughing. She finds a minipad adequate for protection and is often able to remain dry all day. She has had no further problems with enuresis since changing her evening furosemide dose to late afternoon and limiting her fluids after dinner. She can make it to the bathroom and no longer needs the bedside commode. Her perineal tissue is intact, and she demonstrates improved muscle strength. Complications. These include skin problems. A person with urinary incontinence is more likely to have skin sores, rashes, and infections because the skin is wet or damp most of the time. This is bad for wound healing and also promotes fungal infections. Urinary tract infections. Long-term use of a urinary catheter significantly increases the risk of infection. Prolapse. Part of the vagina, bladder, and sometimes the urethra can fall into the entrance of the vagina. This is usually caused by weakened pelvic floor muscles. Embarrassment can cause people to withdraw socially, and this can lead to depression. Lifestyle changes. Drink plenty of water. Watch what you eat. Lose weight. Quit smoking.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.